Good morning, everybody, and thank you very much for taking the time to spend with us this morning to take a closer look at lactose intolerance among different ethnic groups. My name is Julie Meyer, and I'm actually speaking on behalf of Karen Kafer, who is the Vice President of Health Partnerships and Communications at National Dairy Council, as well as a recent victim of laryngitis, and is unable to speak on the call this morning, but I will be speaking on her behalf. We have some excellent experts and some exciting new information to share, and our hope is that you leave this webinar with an increased knowledge and understanding of the current dietary management recommendations for lactose intolerance from the 2010 Dietary Guidelines for Americans, as well as the unintended consequences of dairy avoidance among those with lactose intolerance, and some effective strategies to help people with lactose intolerance enjoy milk and milk-based products, and share with you some key lactose intolerance references with special consideration for key ethnic and cultural groups in the U.S. In addition to this exciting information, we want to make sure this webinar is an interactive experience. So we have included polling questions interspersed throughout to get your input on various subtopics. We'd like to thank Creighton University for jointly sponsoring this webinar with us and making this program eligible for continuing medical education, expanding into conversations with physicians as well. So for physicians, the continuing education information, this is for your reference. Again, we're delighted that we're offering continuing medical education credit applicable to doctors, physician assistants, nurses, and nurse practitioners, as well as, of course, continuing education credit for our dietitians. Please refer to this and related slides, as well as a follow-up email that will provide you with the information you need to obtain your continuing education credit. For individuals unable to attend this webinar, we will turn this recording into an on-demand webinar that also offers continuing education credit available a year after the recording. If you have colleagues that might be interested in finding out more about it. So as we're getting started, it is my pleasure to introduce two expert speakers joining us today to present on this topic. The first is Dr. Jeanette Newton-Keith, a gastroenterologist with specialized training in clinical nutrition at Buffalo General Hospital in New York. She earned her degree in medicine from the Indiana University School of Medicine in Indianapolis and subsequently trained in General Indiana University Medical Center. She then completed her gastroenterology at Columbia and an NIH-sponsored supported fellowship in clinical nutrition at the University of California, Davis. She is an expert on calcium and vitamin D metabolism, lactose maldigestion, and women's and minority health. Her research includes the study of magnesium nurture in obesity, cardiac arrhythmia in obese patients, nutritional risk factors for the development of colon cancer in the setting of obesity, and lactose intolerance in minorities. One of her current projects is an effort to address misinformation regarding lactose intolerance in minorities, as inadequate intake of calcium has been associated with an increased risk of developing diabetes, osteoporosis, colon cancer, obesity, and hypertension. This is what we should be speaking on today. She's a fellow of the American College of Nutrition and a member of the American Medical Association, National Medical Association, American College of Gastroenterology, American Society of Gastrointestinal Endoscopy, American Society for Bone and Mineral Research, and Parenteral and Enteral Nutrition. We also have Dr. Cecilia Pazzo-Folletti, MSRD, who's a registered dietitian and a fellow with the American Dietetic Association. She is an expert on Hispanic communications and serves as the president of the Folletti Association and Latino Health Communications. She is a bilingual consulting firm servicing the food, pharmaceutical, and healthcare industries. She received her master's from Eastern Michigan University and her undergraduate degree from the University of Dayton, Ohio, and has various postgraduate certifications. Cecilia is committed to bridging the knowledge and information gap in these industries. Ms. Folletti was the first Hispanic spokesperson for the American Dietetic Association. She is a recipient of the ADA's prestigious Medallion Award and several peer-reviewed honors. Her communications and regulatory response firm services a variety of Hispanic and non-Hispanic clients and industry-leading organizations. Her past experience includes experience in regulatory response and international media relations as clinical division director for major health systems on the East Coast and in the Midwest. She also coordinated nutrition education for the University of Michigan Medical Students. So as we are getting started, to start with a polling question. Okay. So as we're looking at this, which of the following cultural and ethnic groups would benefit from consuming 3 servings of low-fat or fat-free dairy each day? A, African Americans, B, Caucasians, C, Hispanics, Latinos, D, Asian Americans, or E, all of the above. And if you should be able, there we go, you're able to vote right there. If you just click on to the poll choices, we'll see. Well, there you go. 93% of you recognized all of the above, and that's what we're going to be speaking about today. Since 2003, the National Dairy Council has been surveying healthcare professionals' perceptions of dairy's nutritional value every few years. Respondents are a mix of practicing family physicians, pediatricians, or dietitians. In 2010, the most recent iteration of this survey, we focused on lactose intolerance. Responses from 232 people meeting these qualifications gave some interesting information, and we'd like to share the highlights with you. So low-fat, recent authorities agree, low-fat and fat-free milk and milk products are an important and practical source of key nutrients for most people, including those who are lactose intolerant. Unfortunately, many doctors are still recommending supplements as a primary source of calcium. To further discuss these issues and give us some additional insights on understanding the science and impact of lactose intolerance on ethnic groups, I would like to introduce Dr. Jeanette Newton-Keith.
Good morning. Here are my disclosures as required. But today I'd like to begin by reviewing the physiology of lactose digestion intolerance. I will also share with you some of the latest research and scientific advances that will play an important role in our clinical management and understanding of lactose intolerance. We'll discuss the prevalence of lactose intolerance among Hispanics and African Americans. When we are meeting patients who are being referred for lactose intolerance, it's important that we understand the basic physiology behind lactose digestion. Under normal circumstances, it's important to remember that nutrition absorption is site-specific. So any disease process that affects the bowel will have specific nutrient deficiencies depending on the anatomy. When we think about carbohydrates in general, the salivary amylases in the saliva begin the digestion process in the mouth, and it continues throughout the length of the entire small bowel. On the other hand, protein digestion begins in the stomach, where larger protein sources are broken down into smaller protein sources which enter the small bowel. Pancreatic enzymes result in the digestion, leading to the absorption of amino acids. Fat digestion occurs predominantly in the small bowel due to the pancreatic enzymes. So when we think about lactose intolerance, it's important to remember that lactose digestion occurs in the small bowel. The enzyme that's responsible for its digestion is called lactase. It is a brush border enzyme that hydrolyzes lactose to glucose and galactose. If you look at the villas demonstrated here in the diagram, this is where the brush border enzymes occur. I share this with you because it's important to remember that any disease process that affects or damages the brush border will negatively impact the absorption of nutrients and the digestion of nutrients, specifically your carbohydrates. The lactase enzyme is coded for on chromosome number 2. When we hear about lactose intolerance or lactanon persistence, meaning the loss of the enzyme activity level, there are some important genetic mutations that are associated with non-persistence. The most common is the CC13910, which is associated with most adults in terms of hypolactasia or lactase non-persistence. There are 2 commonly found mutations that result in lactase persistence. So when we look in the old literature, we'll see the terms lactase non-persistence, lactose intolerance, and lactose maldigestion. I want to explain the difference between the terms because they're not synonymous terms. There are 3 types of lactase non-persistence. The first is a congenital syndrome that's very rare. In fact, I've never seen one in all my years of clinical practice, where In contrast, the most common form of lactase non-persistence is primary deficiency. It can occur in adults, but can also be seen in premature infants with underdeveloped GI tract. It accounts for 75% of the lactase deficiency in the world. Bear in mind that this is not a disease. This is the normal age-related decline in the lactase activity level that occurs between the ages of 2 and 20. Every individual has a genetically regulated residual activity level, and the complete absence of lactase activity is rare. And that's one of the ways we're able to increase tolerance and improve dairy food consumption in individuals who are lactose intolerant. In contrast, secondary lactase non-persistence occurs when any disease or procedure that damages the lining of the small bowel, resulting in a secondary or temporary non-persistence. You can see this after a prolonged course of antibiotics, after a viral syndrome. You can see it in celiac disease or inflammatory bowel. Is that the lactase activity generally returns to normally 3 weeks after healing of the mucosa. So that allows us to reintroduce dairy foods with minimal or no absorption, even in lactose-intolerant individuals. Secondary lactase non-persistence does not necessarily result in severe intolerance. When we think about the term lactose maldigestion, it's important to note that this is an intraluminal process that occurs inside the GI tract. When excess milk sugar, the lactose, is not absorbed in the small bowel and reaches the colon, gut bacteria break down the milk sugar to acids, hydrogen, and methane gas. Bear in mind, this is asymptomatic in most adults. Lactose intolerance is a clinical condition that occurs when symptoms are associated, keyword associated, with lactose consumption. This may be the result of either the decreased lactase activity level or from GI distress due to the osmotic effect of the excess milk sugar in the colon or from the breakdown products. In terms of advances, in 2010, the importance of lactose intolerance in terms of global health was noted at the NIH Consensus Development Conference. This was held in Bethesda, Maryland in February of 2010. I've referenced the full report, and I encourage you to review it. This conference was specifically designed to provide healthcare professionals, patients, and the general public with a responsible assessment of the data that's available regarding lactose intolerance in health. There was a 14-member non-advocate panel that wrote the report. There were 22 of us that presented at the conference regarding specific areas in terms of management, treatment, and identifying lactose intolerance. One of the most important statements that came out of this conference is that we need to have a consistent definition. In the literature, you'll see lactose intolerance defined as lactose maldigestion as well as lactase non-persistence. At the NIH Consensus Conference, it was stated that to make the diagnosis, you need to have two components. First, you need to have lactose maldigestion, which is the intraluminal process, as well as clinical symptoms that are associated with the lactose consumption. In terms of making the diagnostic evaluation for lactose maldigestion, the earlier literature from 1966 used the breath hydrogen test. If you recall, I mentioned that gut bacteria break down the milk sugar and produce hydrogen gas. A rise of 20 parts per million over baseline is consistent with the diagnosis. Unfortunately, the original studies used a 50-gram dose, which is super physiologic, because it's equivalent to drinking 4 glasses of milk on an empty stomach. And I think it's safe to say that few people, even those that are consumers, drink 4 glasses of milk. Based on this, you'll see that minority groups and ethnic populations had a high prevalence of lactose intolerance using lactose maldigestion as a surrogate marker. Currently, the gold standard is to use a 25-gram dose of lactose with the breath hydrogen test. Recognizing that it is still super physiologic, it remains the best gold standard that we have to date. The test is 3 hours long. It requires that you blow into a bag every 30 minutes, and for those of you that practice pediatrics, the child has to be old enough to blow up a balloon in order to use this test. There's also hypolactasia genetic testing, which is not widely used because most of the original studies were performed in European Caucasian populations. There's very few studies in minority populations. Mucosal biopsies are not routinely done, and stool pH can be used in pediatric population. One limitation is it's not specific for lactose. Any carbohydrate that's malabsorbed will, and so it's important that the pediatrician evaluate that in the appropriate clinical context. The reason that the NIH felt strongly about testing was that all that rumbles is not lactose intolerance. It's important as clinicians that we recognize the masqueraders, specifically irritable bowel syndrome, celiac disease, inflammatory bowel disease, and even reflux. Gastroesophageal reflux disease can have an atypical presentation. The clinical management in these situations require sometimes pharmacologic intervention as opposed to just dietary changes. The other important diagnosis that needs to be ruled out is milk allergy. The reason this is significant is because it's a reaction to the milk protein, not the milk sugar. Signs can vary from mild to moderate. The things that we worry about most are wheezing, vomiting, itching, and hives, but it can also have problems that mimic lactose intolerance. Rarely, and one of the things that we are always concerned about in the setting of an allergy is that milk allergy can result in anaphylaxis, which is a severe life-threatening reaction. Bear in mind, most children outgrow milk allergy by age 3 years of age, which allows dairy foods to be reintroduced into the diet. We want to do that because of the complete nutrient package, which we'll discuss momentarily. But when we think about the prevalence of lactose intolerance, it's important to understand how often does it occur. We completed a study where we surveyed 2,000 African Americans and compared them to the general population. In contrast to the 80 to 90% that believe themselves to be intolerant, only 24% of our population had self-described lactose intolerance. A more recent study performed by Dr. Nicholas and her group found that only 19.5% of African Americans and 12% of adults overall report being lactose intolerant. So clearly there's a gap. The significance in self-described intolerance is that when we think about health consequences, those individuals who have lactose intolerance had lower intakes of calcium from dairy foods, but they had higher rates of physician-diagnosed diabetes and hypertension. When calcium intake was increased by 1,000 milligrams per day, the risk of these diagnoses, or the odds of having one of these diagnoses, decreased by 1/3. I know of very few medications that will reduce your risk by 1/3. So this is something in clinical practice that we can, this is a place where we can intervene and have a significant clinical effect. The take-home with regard to lactose digestion is that there are a variety of factors that influence lactose digestion intolerance. For example, fermentation of the dairy product, the yogurts, cottage cheese, etc., are sometimes better tolerated. Every dairy food has a different amount of lactose present, so you can consider options that have lower or less lactose present naturally. Gastric emptying tends to influence adaptation. We don't increase our lactase activity level, but that bacteria over a period of time can increase their lactase activity level, allowing for easier digestion of the milk sugar. But most importantly, there's an issue of perception of tolerance. When we asked the individuals in our survey, how did they know that they were intolerant, I want you to understand that there were a variety of reasons. From word of mouth, from friends, some of them didn't even know why they were lactose intolerant. But only 19% of our population had physician-diagnosed lactose intolerance that was confirmed with maldigestion and symptoms, meeting the criteria as established by the NIH Consensus Conference. The reason this becomes more significant when we're talking about patients in our practice is if you ask individuals who are lactose intolerant would consume more dairy food, 81% said yes. what we think is healthcare professionals, where they're coming to us for dairy exclusion or some other intervention. So it's important that we take a step back and look at what the patient's needs are as we consider treatment protocols and interventions. We also looked at 40 controls and 77 self-described intolerant individuals. If you see on the graph on the left, the degree of maldigestion was equal in both groups. It was absolutely identical clinically and statistically. In contrast, when we looked at symptom scores, individuals with lactose intolerance or lactose maldigestion had higher symptom scores at every point. The individuals in the far right column with the 25 grams, which is equal to 2 cups, which is the current gold standard, met the NIH criteria. They had symptoms and documented maldigestion. Notice this group here. They had no lactose present, and yet they had symptoms, which is most likely a learned food aversion. But what was interesting, when we asked all 4 groups if they could discern health present, for these 3 groups, they were unable to distinguish the amount of lactose present, but every individual could tell us when there was 25 grams or the equivalent of 2 cups present. So this data is consistent with earlier literature showing that up to 12.5 grams or the equivalent of 1 cup could be tolerated in lactose-intolerant individuals with minimal or no symptoms. This becomes important when you look at the work that was performed by Dr. Bachowski at Meharry. He looked at lactose-intolerant individuals, self-described, who had lactose maldigestion and found that their calcium intake was about 380 milligrams. He compared that to individuals who were dairy consumers, even though they had lactose maldigestion, and found that their consumption was 730. Prior to that, when we looked at large databases, we assumed that the calcium intake in African American women was about 520 milligrams. But the thing I want to point out to you is that both groups failed to meet their recommended calcium intake. And so the question becomes, why is that clinically significant? It's clinically significant because lower calcium intake has been repeatedly associated with a higher BMI. Your body mass index is a predictor of your calcium intake, and it also influences momentarily. So in terms of lactose intolerance among different ethnic groups, it's important to look at racial, cultural, and communication challenges. The 2010 dietary guidelines recommend 3 servings per day. However, most Americans are consuming 1.7 servings per day of dairy foods. Hispanics born in the United States consume less than Hispanics born outside of the United States, but African Americans continue to consume the lowest amount of all ethnic and racial groups. When we think about dairy consumption among Hispanics, 28 to 40% consume less than 1 serving per day, increasing their risk for health consequences associated with lactose intolerance. If you look at different subgroups or nationalities within the Hispanic community, Mexican Americans consume on average 2.1 servings per day, whereas other nationalities have varying levels of intake. If you look at acculturation based on language alone, which is just one of many ways to address acculturation, milk is the number 2 beverage at risk as Hispanics acculturate to the U.S. community. So what are the key research findings that we need to be aware of that will influence our management? I briefly alluded to the fact that diet quality was decreased when there was decreased dairy foods. This work was done by Dr. Connie Weaver at Purdue and Dr. Haney in Nebraska. They looked at 272 healthy premenopausal women, 7-day food diary, and they gave a score of 1 point for each of the 9 key nutrients consumed at 70% or more of the recommended daily intake or allowance. A score below 5 was associated with poor diet quality. When they looked at the women, 151 women had low calcium intake, primarily due to low dairy food intake, and they had poor diet quality scores. In contrast, the 121 women had high dairy intake, and they had a high quality score. One might ask, well, what if we just supplement calcium? Does that improve the diet quality score? Well, They did that. And what they found is in spite of supplementation, 56 of the participants continued to have poor diet quality scores despite adding calcium. And you may ask why. The reason is because of the nutrient package. We talked about African Americans' intake of all ethnicities. The important thing from our study was that the African Americans surveyed were unaware of the health benefits of the dairy product, and yet they were 383 times more likely to be vitamin D deficient compared to the population. In our study, 25% were self-described intolerant, whereas in the more recent study, it was 12%. Regardless of the low number, the number one reason was real or perceived intolerance. So when we think about hypovitaminosis D and the clinical significance, we have to remember that it's associated with metabolic syndrome, obesity, osteoporosis, certain cancers, and other chronic diseases that we can prevent. There's inadequate sunlight in many temperate climates. People with darker skin pigmentation require longer sun exposure to generate the same levels of vitamin D, where more recent data has identified ratio in terms of vitamin D absorption. Please note that just this July, the new vitamin D supplementations were made available, and the reference is noted in your handout. In addition, there's a reference by the Institute of Medicine documenting the need for vitamin D repletion. Historically, we thought a level above 20 was normal. We are now finding that levels below 20 have been defined as vitamin D deficiency. Levels between 21 and 29 are identified as vitamin D insufficiency. And using the Institute of Medicine guidelines, the level of intake is about 30. So as we go forward, it's important to remember that there are rules of three. There are three types of lactase non-persistence. Secondary lactase non-persistence resolves approximately 3 weeks after mucosal healing. Milk allergies usually resolve by age 3. The optimal level of intake is 3 servings per day. We can reduce the risk of diabetes and hypertension by 33%, and it takes approximately 3 weeks to adapt to new lactose digestion. In conclusion, there are racial and ethnic differences in the prevalence of lactose intolerance. However, they're not as great as previously reported in the literature. There are some attended health consequences associated with lactose intolerance and dairy avoidance. Therefore, racially and ethnically focused and culturally sensitive interventions are required. And at this time, I will turn the presentation over to Cecilia, who will share additional information in this area. Thank you.
Thank you, Dr. Keith. That's a great segue. And I think in this section now, to build on the wonderful knowledge that we've gotten just in terms of the biophysical factors involved, I'll have a focus now on exploring 5 questions that we're going to really get into in this section. The first would be to explore, why are we talking about this issue? The second question we'll address is build up a little further on the estimated prevalence of LI, or lactose intolerance. The third area of exploration in this section will be dietary implications of LI. Then moving on to tips for tolerance, and I'll end with some successful strategies for healthcare professionals, because really there are solutions. So for the first section, why are we focusing on lactose intolerance? Obviously, there's new science. With the consensus report that Dr. Keith had referenced and that we listened to intensively in February of last year, there's excellent output, and I would also reiterate Dr. Keith's comment on making sure that you try to get a hold of that literature, those reports, and review that literature yourself as well. But the changing face of America is really another important reason why we're exploring this issue. We no longer are thinking of America as a melting pot, but rather many are referencing it as a salad bowl. And the reason for that is that we're saying that ethnic enclaves are living and retaining some of their habits and dietary habits together, and lactose intolerance will tie into this. So it's important to understand that there are opportunities to help and assist the dietary intake profile of important growing racial and ethnic groups, and to add some immersion comprehension of cultures As a past GI dietitian, in relation to obviously now we see this trend, and you know it's here. This is a recap of the 2010 census data, which helps paint the picture of what's happening with the white population decreasing, and certainly the minority group now becoming a majority minority in many states and perhaps in your locales. We are going to focus today on a couple of the groups who have perceptions or real lactose intolerant syndrome, and deal with them a little bit more than some of the subgroups, and that would be the Hispanic or Latino group at 16.3% of the population right now, and the African American community at 12.2%. Certainly the Asian American and East Asian groups are particularly vulnerable, but in terms of critical mass of population, these two groups will be ones that will be very key just from a frequency of perhaps your patient interaction. Again, it does depend on your locale. When we look at what's going on with the underage group, this is a trend that's particularly important because we know that bone health and healthy development in children is really critical. And so to look at these numbers in terms of population will be helpful also just to get a sense of what's going on in this under 18 age group that really are potentially high risk for low dairy and calcium intake, as well as a whole nutrient package, which is accompanies dairy products. So children, when we look at the Hispanic population, 23.1%, Americans 14%. The fastest growing for Latino population, and I think it's important to realize that the data is indicating to us that by 2025, not that far away, 1 of 3 children will be of Hispanic ethnicity, making it an even more important issue as they become our future generation of either healthy or unhealthy Americans. This next slide from USDA just is a reminder of not only the criticality of intake of calcium by children as a vulnerable group in particular, but also because the particular racial and ethnic groups that we're talking about who already may have calcium deficiencies or are prone to low, as you have seen the data, some of the data intakes already, are also compounded by the problem of perhaps having very low food insecurity. And so this graph helps point out to us that when we're looking at Hispanics, we're looking at relatively high percents of low food insecurity. So not only do we have reasons for why, and we'll get into them in just a little while about why we may see these low intakes, but in addition to that, there's a compounding economic factor that may be an access issue that further may exacerbate the complications of unintentional removal of low dairy intake. In terms of that population trend, really just here as a phase or just something that we're going to see as a real trend? And the answer to that is that indeed, if the trends hold up as they're projected to be, we will not see these numbers dissipate. In fact, they will continue to increase. And so by 2025, 30%, 2050 rather, 30% of the U.S. population will be of Hispanic ethnicity. And a reminder that the Hispanic population is unified by language and includes over 23 different subgroups. So their intake of dairy, their habits, and their perhaps presentation of LIs may be very variant as well. So the projected population by group we see is listed here, and I have included the Asian American because they are also a very fast-growing subgroup. And though we're focusing on the Latino and African American, this is what the spread looks like, and you see the non-continuing decrease while these other minority groups become a much larger, substantial proportion of our population. So in addition to the science, the numbers tell us that we really do need to pay attention to this growing population and their LI perceived or real syndromes and what it may mean to their dietary status. We have now a polling question for you, and I'll read it and ask you to respond, and we'll see what that is. The majority of African Americans, 50% or more, in the U.S. are lactose intolerant. Is this true or false? I see that now we have almost 42%. We have 77% of respondents. Percent of you, almost everyone has queued in here at 97. We've got everyone responding. and what you have said is that it's false. And so that means you were listening pretty well with Dr. Keith's numbers there, and know that perception versus what we know may be two different things, and we are going to explore that now. So what about this estimation? The reality is that reliable estimates of U.S. prevalence rates for OI really are not available, except that we have some good self-reported data. And you've seen some of it, and we're going to explore that just a little bit more. So the population to have ethnic or racial populations that do experience LI are, in fact, the same groups. It's East Hispanic, all of that, real or perceived. And so the findings that suggest that there may be past overestimations, and they could be due to a multiple set of factors, some of which Dr. Keith has alluded to prior. So in looking at this data, there was previous data done back in the early 1990s, and this was mainly done looking at historical evidence of, why do we believe that some individuals may be lactose persisters or not, and trying to understand why. This data that was done and reported in Gastroenterology back in 1994 really looked at a group of individuals from Finland. It was done in Helsinki, and also included genetic testing as well. And basically, the data was not representative, obviously, of the U.S. population. And so what we see here is that there are reasons why we looked at older studies, but how do they hold up today? There's really few data available from recent USD outcomes, and the data is likely not representative of the U.S. overall population. And the outcomes usually in the studies that were done did not directly assess LI, but instead they assessed either an inability to fully absorb lactose or somewhat subjective symptoms that were possibly prone to bias. So there has been a lack of clear, clinically meaningful, and commonly accepted definitions, especially for U.S. Population prevalence. So we believe that the rate is lower into adulthood, of course, for Northern European descendants and higher for some of the other groups, but we think that the numbers are well overstated. As reported prior, you saw this graph by Nichols study. This was included here. And in the Nichols data, what we have here is a demonstration here of a different set of results. The prevalence here, which was published in September and October in Nutrition Today, surveyed a national sample of adults in these three ethnic groups and found that the age-adjusted self-reported lactose intolerance rates were 12% for total respondents, with 7.72% for Europeans and 10.5% for Hispanic Americans and 19.5% for African Americans who consider themselves to be lactose intolerant. So these new findings indicate really that the prevalence rates in practical life settings may really be lower than originally suggested. So that's an important, I think, take-home for health practitioners. And when you look at this data a little closer, some of the subgroup data information were for African American males. The cut was about 15.42%. For African American females, 20.8%. For males, it was 8.42%. And for Hispanic females, 8%. So again, a lot lower than our perceptive self-reported data as previously discussed. So these new estimates may be important here, but what we really know is that there may be reasons why the meta-analysis studies that were shown before really showed in the work by Saviano that in the meta-analysis there were 21 clinical studies that included African Americans, Hispanics, Asians, and Caucasians, and they were all lactose maldigesters, but it was found that lactose was not a major cause of symptoms following consumption of the usual intakes of dairy foods, such as 1 cup of milk. So the meta-analysis study is supporting this direction. Another reason, and the bullets here need to be here, is that we may be seeing an effect of a learned response in households where, say, African Americans or Hispanic parents may have perceived themselves to be lactose intolerant. They may eliminate dairy as a routine option, and next generation see this and also may have a learned response, and so that's a hypothesis out there, as well as a lack of role modeling of acceptable levels in small quantities, which could be a beneficial aspect that's missing because we have this other dynamic going on. Another estimation could be that maybe there's limited exposure and availability so that we can actually see this threshold response in households that don't include dairy, except in small quantities, in African American households or Hispanic households. There may not be the opportunity to have individuals in that household experience a threshold in small quantities, i.e. 12.5 grams or less, and so therefore they may not have a learned response that's a positive response. And lastly, the tolerance option trials may not have been available in the households. I don't know about your neighborhoods, but certainly I myself have worked with many lactose intolerance patients and myself an experiencer of such symptoms, and I know that I never have products available like we have today. Ice cream, cottage cheese, milk that all have the lactose removed so that therefore I can still enjoy the dairy benefits in excess of maybe my usual dose of regular dairy. So what are these dairy implications that we need to pay attention to in terms of the diet? Well, the Dietary Guidelines 2010 clearly point out and recommend that we need to include milk and milk products in our diet. These are short-form nutrients in the American diet for all age groups. And then you can see that we have particularly vulnerable groups with these ethnic and minority racial groups. For children, the 2010 guidelines are clear that ages 2 to 3, 2 cups of milk per day or equivalent are the recommendations. For children 4 to 8, the new recommendations are 2.5 cups. For girls 9 to 13, 3 cups of milk. For girls 14 to 18, 3 cups of milk. And the same for boys. So the recommendations are clear that we need to include and remedy the shortfall of nutrients, and the nutrient package in dairy is so powerful. It includes not only the non-essential nutrients, but we have additional, even up to 16 different nutrients. So again, the calcium supplement substitution is really not as beneficial as getting this whole array of nutrients that can be incorporated easily into the diet at a relatively low cost to patients and consumers. This information is supported not only through the dietary guidelines, but also through American Pediatrics and through other leading authorities so that we are all on the same page about the importance of dairy in the diet. Well, when it comes to low dairy ethnic groups, you have already heard some information. This just reiterates, again, the same data in a different fashion. But, again, it's just helping us understand not only short-form nutrients for everyone, particular short-form nutrients for the 2 largest growing ethnic and racial groups. And you saw this slide. I just want to give you a different take on the acculturation in milk consumption. I think it's important to understand acculturation as a concept. And acculturation by definition, so when you look at this slide and review it, not only does it perhaps represent some of the subgroups in the Hispanic community, but acculturation is based on a multitude of factors. It can be length of time in the U.S. It could be defined to include the language preferred at home. It could also be defined as a relationship preferences with friends, i.e. Hispanics versus non-Hispanics. I'm just defining for you acculturation. Prior life experiences, the place of country of origin is also part of the definition of acculturation. And acculturation may also include levels of education. So when you look at this data and we say acculturation and milk consumption, what's happening, this is the kind of definition that should be wrapped around the concept of acculturation with, again, over almost 23 different subgroups. So the good news is, and you heard it a minute ago, is that in recent research, we know that individuals want to consume more dairy in their diet, and the data demonstrates this. So that's the positive news for health practitioners. So we understand there's a need, there's a clinical solution for it, there's a recommendation, and there are consumers that are willing to take those steps. So it's really beholden on us as health professionals to bridge that gap. We'll now take the next polling question, which is, what percentage of the Hispanic or Latino population living in the U.S. do you believe consider themselves to be lactose intolerant? And please respond. And the tallies are almost all in. And so will we go to the answers now? And we see where most of you lied. And again, you were listening to what the survey data says and have responded appropriately.
And now we're going to go ahead and look at some real areas that health professionals can make a difference. And this is a concern because we want solutions for patients who are experiencing symptoms from lactose intolerance. So we're going to focus now on tips for tolerance. One of the first principles that I think will really help you to help your patients is the concept of going slowly to really build up tolerance. In this particular tip, we really are helping individuals to get their 3 a day with fluid milk. And remember that the dietary guidelines help us guide our patients. If they're children, 2 to 3 years of age, 2 cups. If they're children, 4 to 8 years of age, 2.5 cups. Girls, 9 to 13, 3 cups. And girls, 14 to 18, 3 cups. And boys, 9 to 13 and 14 to 18, 3 cups a day. So this 3 a day is very important to meet calcium and to meet the powerhouse of nutrients that we find in dairy. So to start with a small amount of milk daily, to reintroduce lactose to the intestinal gut, we will want to begin slowly. And in my experiences, I would work individually with each patient because their tolerance is quite variant. So you increase slowly, perhaps starting with as little as 2 ounces of milk. Allow 2 to 3 weeks for the gut to adapt, to build tolerance to the lactose. And in that way, you're going to help your patients increase their ability to digest the lactase and move along in terms of the guidelines that we know are helpful to them. In terms of the next slide, we are here looking at a resource that I think is really helpful because remembering that certainly dairy or dairy equivalents matter, and patients may in fact tolerate different types of dairy sources. So this next chart helps us understand how many grams of lactose are present in different foods. Milk, irrespective of the fat content, has 13 grams per 1 cup. And remember, most individuals with lactose intolerance can tolerate up to 12 grams at one time, but again, the introduction slowly is what matters here. So lactate milk, of course, has 0 grams of lactose in it, and you see that our cheeses are very low, yogurt being about 13 grams, and ice cream about 4 grams. And remember, there's also now lactose-free ice cream as well. So this resource can help you bring a variety of foods to the patient with lactose intolerance syndrome, and that way reintroduce slowly as that first principle. The next tip on the next slide reminds us about the variety of products that we have now that are lactose-free. So in addition to sipping it and introducing it slowly, trying different types of products that have no lactose. I know in the past we did not have this available to us. Now we have lactose-free cottage cheese, lactose-free cheeses, milks in different flavors, ice cream. So really lots of ways to enjoy dairy without experiencing the potential gastrointestinal disturbances that individuals may be used to. So opt for those lactose-free milk products and remind your patients that these are real milk products. They just have a lower amount to 0 lactose, and they have the same essential nutrients as regular dairy, and they taste great. The next tip is about stirring. It's been found that it's very helpful to be able to mix milk with foods, and this also is another way for patients to enjoy reintroducing lactose to their diet. So blending it with fruit or drink milk with meals, making sure that they're enjoying stirring it into other products like soups, cereals would be another tip. Another way to make sure that we're getting that dairy base that we need is to try slicing it introducing that dairy in a slow way again with different types of cheeses. And in dealing with ethnic groups, it would be helpful also to realize that we want to be using cheeses that are familiar to those either racial or ethnic groups in this case, whether it's queso fresco for Hispanics or whether you're using a Colby or a cheddar type cheese, different types of foods for African Americans, making sure that you remind them that this is another easy way to be able to reintroduce dairy in with veggies, pastas, on salads. These are practical ways to be able to reintroduce it. And the last tip right here is to spoon it. It's easy to really digest yogurt, and remember that the yogurt does have the live cultures, which are very helpful to that intestinal gut in terms of reactivating what's going on with those villi, and so that's a really helpful way to get the gut back healthy again, and that's what you want to help your patients do. And so spooning it is another way of reminding you to use yogurt with fruit or vegetables or also cereal, or even trying it as dips or as a dressing. There are also easy ways to cook with dairy. And so remembering that, again, we want to go back to traditional dishes and traditional recipes, soups made with milk. And, here on this slide you can see that we're reminding you again to think about that ethnic and racial reintroduction. So whether it's a quesadilla or you're using some sort of chili dish, that it be something that your patients can respond to in a familiar kind of way that's culturally sensitive. And many traditional foods incorporate milk and milk products, especially for Hispanics. And so this would be a great way to start. You can also find additional recipes at www.nationaldairycouncil.org, and that would be another way to help you help your patients. And there's more than one way to enjoy dairy. So remember, hot foods, cold foods, using lattes, warm milks, hot chocolates. These are all different ways that you can have food taste great again that has dairy in it without having the problems that are associated with lactose intolerance by using these tips that we've talked about. Now we're going to switch to some successful strategies for health professionals. And really from a clinical standpoint, you really want to pinpoint the problem and move beyond the belly aches, if you will, to making sure that you have gotten verbal or written confirmation, as we mentioned prior, using the hydrogen breath test, and if it's a child, the stool acidity test. Many people who say they have trouble digesting milk have actually never been diagnosed with lactose intolerance by a health professional, as mentioned before. And while gas, bloating, or abdominal discomfort can be uncomfortable and very disruptive, it's difficult to confirm unless we've gone to that due diligence of actually confirming the diagnosis. And so there is this two-step process. First, you would question with screening tools to help identify patients who complain about GI disturbances or other discomforts. And secondly, if they're experiencing these disturbances related to what we believe would be lactose intolerance, then you would administer a lactose tolerance test using the hydrogen breath test. And then from there, we can move on to implementing the steps on an individualized basis. So the next strategy then what we're talking about for health professionals to help patients be to stay informed, understand how to minimize these lactose intolerance symptoms, and to help your patients view dairy as an investment in human health, not just food consumption. It also tastes great, but it also truly is a nutrient package that can't be replicated with other kinds of either calcium supplements or other foods very easily. So become educated on the current guidelines, which we've reviewed. Secondly, asking questions. Ask and inquire about these lactose intolerance core questions when you're taking that medical history or dietary assessment to help reduce the dairy nutrient deficiencies that may arise from long-term non-use of dairy products, which really is problematic. I've had patients who have had, breaks of different bones in different areas because they've just completely done away with dairy, and this would be even in, I had a young male who had experiences with this because he just got rid of dairy altogether. And so this is a very negative consequence. Advising patients, encouraging patients to formally be tested, providing the guidance on the gradual reintroduction of dairy into the diet, and making sure that you're really looking for those who are at risk. revealing positive linkages between dairy and the key disease states, and certainly for pregnant women, the elderly, hypertensive, diabetics, and other risk groups. We want to make sure that those who may even be marginally affected can be improved by protecting against nutrient insufficiencies. Educating your patients is key, disseminating dietary guidelines to patients and making sure they're aware of what is needed and what the current recommendations are. In terms of techniques to connect to your patients, making sure, and we found this through focus groups, it's so important to use visual aids and graphics and photographs that actually reflect the group that you're working with. Oftentimes brochures are handed out and people say, well, I looked at that brochure, but the people on the front didn't look like me, so I didn't think it was important for me. So this seems like such an oversight, but having materials that are culturally and linguistically appropriate is really important. And facilitating interaction with bilingual or bicultural staff is another way to connect. They need to feel comfortable that their provider can, in fact, communicate with and understand their symptoms. So there's new class, culturally, linguistically appropriate services, mandates, even in joint commission language. So we know that this is a really important area to focus on from a regulatory standpoint, but also just to provide quality interactions with your patients. Another concept in dealing with racially and ethnically diverse populations is to concentrate on preparing for family-centered education. I'm Hispanic, and I know that in going to a doctor's appointments with my family members, there are many family members that attend the meeting. So unlike what we may be used to in the Anglo populations or other populations, be prepared for the room arrangements to be conducive to good communications with family-centered education. Connecting with community and faith-based leaders is another technique because they are key influencers to your population. So letting them know that there are solutions and providing educational programs is another way that you can help your community get healthier and reintroduce and include dairy in their normal, usual intake and enjoy the great taste and benefits as well. The next slide really helps us understand that there are differences in health benefits and the perceptions of health benefits by different diverse groups. Latinos, for example, describe health as a state of well-being, and they're incorporating emotional and physical as well as sometimes even spiritual well-being in that description. So it's a more holistic approach than what we might perceive as other groups who are trying to identify what health means to them. So understanding that different groups have different orientations, and in this segment, I've outlined here a few things: country of origin, years living in the U.S., socioeconomic stats. All these things influence how we perceive health, and certainly a healthy diet includes dairy. The next slide just is a reminder of language and the kinds of differences that exist in households, those that only speak Spanish, those who are predominantly Hispanic or speak Spanish at home. That's 44.3%, quite a few. So trying to understand what the language preference is for your patient and how they want the materials would be an important query so that you really can get your health messages through to them. The next slide really is just a quick snapshot of cultural values. And again, just pointing out that different groups respond to values differently. Family first, and why it's important to reintroduce dairy and get the health benefits from a both prevention as well as a disease-oriented approach may be important for the family to understand, and that you might want to go at that messaging through your family-centered education for Hispanics, for instance. Overall, then, the communication tips are that we want to help our patients recognize that, food often means more than energy. It's a key part of culture. Sometimes it means love in some of our cultures as well. So addressing what food means beyond just the nutrient component is sometimes a space we may not be as comfortable with, but it may be a value that's very much held in esteem by some racial and ethnic groups, and you want to connect on that component. Addressing misconceptions about the nutritional value of dairy foods is key as well. They may not have the fundamental knowledge about the powerhouse of 9 essential nutrients, 16 additional nutrients contained within dairy, and why it is so important to health. So tailoring those kind of messages. The next slide helps to reiterate what some of those tactics, successful tactics may be. For instance, if you choose to use the opt and taste lactose-free products, you may communicate that by reminding the patient that lactose-free milk has the same nutritional value as regular milk. And the strongest messages when you're communicating with your patients are those that, through focus group research, has shown provide multiple benefits, where you're showing that your recommendation has multiple benefits. And in this case, it's nutrients you expect from milk, it's wholesome and fresh. And again, sometimes patients may perceive that lactose-free products may have been manipulated in some way, and so they're not wholesome and fresh when in fact they are. So making sure that your messaging demonstrates the multiple benefits would be key. Messages that can be targeted for consumers and patients with early onset of lactose intolerance may be that providing solutions are important to minimize harmful long-term effects. So phrases like, you can lower discomfort by trying these easy tips, or lactose-free milk is easier to digest than regular milk. This would be a way to really connect with those who have early onset LI symptoms. For those with more frequent LI symptoms, you may want to message off of the fact that the body still needs 9 essential nutrients, and dietary guidelines recommend. And this might be a way to connect. And then for those who are middle-aged consumers with LI, you may want to try messaging that is family-directed, such as the American Academy of Pediatrics recommends that children with lactose intolerance can still consume dairy. Here's how. Or your whole family can enjoy lactose-free milk because it's 100% real milk. So these are messages that can be targeted. So in summing up really why we're coming to this place of helping patients bridge to reintroducing dairy, it's because we know as health professionals that there are enormous benefits to a nutrient-rich diet, and that includes dairy and meeting the Dietary Guidelines 2010 for all patients, including those with LI. So lactose intolerance is a real clinical syndrome, but it should not limit dairy consumption, and it can be managed appropriately. We certainly want to be empathetic to the symptoms as well as the concerns, but they can be addressed and managed in a culturally sensitive manner. And you now have scientifically sound evidence-based tools, especially with the work with the NIH Consensus Conference, to address these barriers to calcium in dairy foods. The consequences we know unintentionally eliminating dairy include not only degradation of diet quality, but we compromise bone health, potential weight management, as well as cardiovascular disease predisposition. So we want to make sure that we get dairy back in the diet. Last but not least, the majority of symptomatic individuals diagnosed with LI can likely tolerate up to 12 grams. So help your patients get there. Deal with their symptoms. You as a health professional are certainly the key to making sure that you get your patients back on track to a more healthful lifestyle. So in ending, I appreciate the time to talk to you about this. I'm going to turn the session over now back to Julie Myers.
I think at this point we'd like to summarize, and actually it's good timing since it's almost time for our Q&A session. So basically in summary, first we'd like to thank, of course, Cecilia and Dr. Keith for their information. And let's take a look at some key takeaways as we're summarizing slide 95. Yep. Basically, as you see, lactose intolerance that you're working with, and dairy avoidance can have health consequences. For healthcare professionals, it's key to personalize the approach to helping people achieve the recommended 3 daily servings of dairy. We hope this webinar encourages you to respond to our call to action, which is to help correct misperceptions about barriers, perceptions, and prevalence of lactose intolerance among your colleagues, clients, and patients. To encourage clinical lactose intolerance diagnosis. Without a clinical diagnosis, people may be improperly diagnosed. To help communicate strategies for consuming dairy foods with lactose intolerance. And to consider tailoring your client and patient communications to an individual culture as well as their individual preferences. Here are a list of some resources that are available to you. There will be a follow-up. We will be sending you a follow-up email with instructions for obtaining continuing education credit for physicians, dietitians, nurse practitioners, physician assistants, and nurses. Dietitians do not need to take a post-test, but the other eligible health professionals do. Please visit nationaldairycouncil.org to access the Lactose Intolerance Health Education Kit, which includes a variety of resources on lactose intolerance, including a listing of recent research, scientific summaries, presentation handouts, and more. We will be posting a newly updated report, Lactose Intolerance Among Different Ethnic Groups, with our Lactose Intolerance Health Education Kit. It will include extensive information on lactose intolerance and will be a very useful resource for health professionals to reference. And included in this kit is also a new white paper entitled Unintended Consequences of Dairy Avoidance, authored by Dr. Keith and other lactose intolerance experts. At this point, we'd like to open up the conversation to some Q&A. We'll be having Q&A. If you would like to ask a question, please go to the Q&A button, fourth from the left on the side, and go ahead and ask a question. As we are getting started, I'd love to just get some questions going since we don't have a lot of time left. Specifically, a first question we have that we got was, how much milk should a person consume when slowly reintroducing dairy? And I'm going to go ahead and open up that question up to Dr. Keith to get started.
Thank you, Julie. When we're talking about reintroducing dairy foods back into the diet, many consumers will be resistant. I'm lactose intolerant, and it was about a year before I was convinced by my healthcare professional to start again. One thing I would do is, if you're talking about fluid milk, begin with 2 to 4 ounces cooked in foods, and then gradually add. The most important thing is to have it with a meal that contains protein and fat. The other option is to begin with foods that were the least symptomatic or best tolerated, such as yogurt and cheeses, aged cheeses in particular. The key is to start small and gradually increase, but really helping them to understand the scientific reasons why we're recommending the dairy food to go back into the diet. Again, it boils down to the nutrient package and the prevention of certain chronic diseases.
Great. Cecilia, are you back? Okay. So, Dr. Keith, yes?
I'm here.
Okay. So another question, how do you get a patient to trust trying dairy again when they're concerned about some of the side effects?
Having experienced them. Again, the most important thing is when I thought about the why, the prevention of diabetes, hypertension, the treatment of obesity, all being prevented or improved with dairy consumption, then it became a risk-benefit. Explaining the facts, helping them to understand why they need to do it, and then explaining how to get it done with minimal or no symptoms. 81% of our patients are telling us they want to consume more food, and so the tips for tolerance are very, very important.
Great. We have another question that came in. Are there any common solutions for lactose intolerance that cut across different ethnic groups or work for all ethnic groups that you found in your practice?
I take care of African American, Hispanic, and Caucasian patients, and I have found that if you start with foods that have been well tolerated in the past, if you start with giving them the facts, it's regardless of culture or ethnicity or race, if you give them the scientific facts and explain the why, and then start small and gradually increase, it has been beneficial in all my patient populations.
Great, thanks. Here's another question we have. Regarding the tip for slowly reintroducing dairy into one's diet, expanding upon that, will all ethnic groups be able to tolerate this, or are certain groups able to tolerate this more than others?
I have found that my male patients seem to tolerate foods a little bit better than my female patients. And the one question that I would ask as a gastroenterologist is there an underlying functional bowel or irritable bowel component that maybe increases the prevalence of self-described intolerance among women? But again, the most successful thing that I've done in my clinical practice is after I sit down and explain the why, give them a consumer-friendly diagnosis and help them to understand that you can have yogurt and cheeses and still have the nutrient package from dairy foods. You can mix it in foods and give them tips for how they can increase their consumption. Dr. Saviano found that they took 100 girls to calcium, and at the end of 3 weeks, 75% were tolerating dairy foods with minimal or no symptoms. The key things that they were doing were they started small, they gradually increased, and consumed the dairy foods with a meal that contained a protein and a fat. If you look at the myplate.gov, the plate has protein with some fat in it, fruits and vegetables, and whole grains. So that nutrient package, combined with the dairy food, resulted in optimal health outcomes when we're talking about the dietary guidelines.
Great, thanks. We have another question here. Could you please expand upon the link between vitamin D and calcium, milk, and colon cancer?
Absolutely. Vitamin D upregulates calcium absorption. And so without vitamin D, you don't absorb the calcium from the diet. We know that there is downregulation of genetic changes associated with colon cancer. In other words, you see fewer polyps, you see fewer cancers in those individuals that are consuming high amounts of calcium and vitamin D. When they looked at supplements alone versus calcium from food sources such as dairy foods, the whole food consumption resulted in the lowest risk of developing a polyp and colon cancer. And so, in addition to dairy foods, the consumption of fruits and vegetables are the things that I recommend for any of my patients that either have polyps or at risk for colon cancer. And again, it has other health benefits globally as well.
Great, Dr. Keith. I think we have time for one last question. Many physicians will order lactose-free diets when a patient presents with GI distress after a bout with difficulty. How long should you wait to introduce dairy, especially since residents may not be able to comprehend the scientific information?
What I generally do is if they've had some kind of GI distress for any reason, I usually wait a couple of weeks and then re-challenge. Remember, the lactase activity level will go down if the mucosa is injured. So if you wait about 3 weeks, similar if you had a viral syndrome or GI distress after antibiotics, you want to wait about 3 weeks. That typically gives time for mucosal healing. And then I try to start again. In the meantime, if you use yogurt and aged cheeses as opposed to fluid milk, in most of my patients it's been well tolerated, and there seems to be less resistance. The other thing is flavored milks have a little bit of fat in them, and that also helps to improve digestion, both strawberry and chocolate. And so these are some things that you can utilize to instance and have people try once again.
Great. Thank you very much. Well, it looks like we're at time. I do believe we have Cecilia back, so thank you very much, Cecilia, for your participation, Dr. Keith as well. And thank you, everybody. Please keep your eyes open for follow-up emails with additional information on your continuing education credits. Thank you.